All right, so what we're going to do is we are going to talk about the different functions of the kidney, okay, which I'm going to turn your papers over because you already know this.
Okay.
And then we're going to talk about the problems that happen when that function breaks, whether that be AKI, CKD, ESRD, whatever it is, the function breaks. And then we're going to do the nursing care. Okay, we're not going to spend a ton of time in the nursing care because it's a patho, but I want y'all to at least have an idea so that way you're prepared for next semester, okay? All right, give me a function of the kidney. Filters waste. Okay, which waste does it filter? BUN, creatinine. It does help with some uric acid or urea. A tiny bit of ammonia, right? The liver gets rid of most of the ammonia. But remember, when the liver gets in trouble, it's always going to be like, can you help me out? Yeah, okay. All right, so if it does that, okay, and that function breaks, so the patient's had a kidney injury, acute kidney injury, or they're in renal failure or end-stage renal disease, whatever it is, that function doesn't work anymore. So can we filter waste?
No.
So where are they going to build up? In the blood. Yes. Okay. This is like you with blood pressure. Yeah. Okay. So that means that in the blood, what are we going to have too much of? What? BUN, creatinine. So those are going to elevate. Go on. But just stay on waste for right now. The uric acid is going to build up. Now, uric acid will go into every part of your body and wreak havoc because it's going to try to find, like, I got to find somewhere to be, right? Okay, so it's going to build up underneath the skin and they're going to get, which is called pruritus. Pruritus is itchy, right? They may also call it uremic frost. All that waste is going to build up underneath the skin and they're going to itch everywhere, okay? It also likes to build up in the chest cavity. That is called uremic pleuritis because this is your pleural cavity. So how do you think it feels when they take a deep breath? It hurts like all holy hell and they got chest pain. Yeah, it builds up in the mouth and that is called uremic fetor, poo breath. When they open their mouth, it smells very bad because uric acid is all built up in their mouth, builds up all in their face, and that's called uremic facies. Okay, so they get like a brownish discoloration to their face. Okay, where does ammonia like to go other than the kidneys? Where's the other place it deposits? Huh? Brain. It goes to your brain and causes encephalopathy. Encephalopathy means like your brain is kind of swollen, not doing so good. Yes. Come to find out your brain doesn't like to sit in straight ammonia. This is shocking. How do you think they feel with all these waste products in their body?
Horrible.
Horrible. So they have malaise and fatigue and they're going to get frequent infections because basically their blood is full of, yeah. Yeah. We call it azotemia. What is azotemia? Emia. Blood. Okay, so it's a buildup of all the waste products in the blood. We call that azotemia. Do you understand?
Yes.
Okay. So how am I going to fix all of this waste? Got to get it out, but the kidneys can't do it. Dialysis. They're going to have to do dialysis. They're going to take out all of their blood, filter it through a machine, and give it back to them all nice and clean. That's what dialysis job is. Obviously, it doesn't take it out all at one time. That would be death. It's like rotating. Okay, but we need to watch these levels. So I'm going to watch BUN. I'm going to watch creatinine. I'm going to watch their ammonia levels, their uric acid levels. Oh, uric acid also likes to build up in the joints. What's that called? Gout. Okay. Oh, really? Damn. Okay. So if we're worried also about ammonia in the brain, then we need to do neurochecks and seizure precautions. Very good, very good. There are 3 drugs that treat gout: allopurinol, probenecid, and colchicine. So if you see those on your chart, those are to treat and to decrease the uric acid in the body. Okay. What is a drug of choice to get rid of ammonia? We did this already. Yeah, we did it. Have we done GI or no? No. Oh, then I haven't done it with you. It's lactulose, which is, do you know what lactulose is? You've probably given it at the hospital at some point. It is a sugar, but it makes you poop. It's a laxative. Okay. And then neomycin is the other drug of choice. What is neomycin? It's an antibiotic, which makes you poo-poo. So they're trying to help you get rid of ammonia through the poop. That's much better than getting rid of it through kidneys or building up in the brain. So that fun fact, lactulose and neomycin, you will see on a million nursing school exams in lots of different ways. Those are the drug of choice for getting rid of ammonia and preventing hepatic encephalopathy or treating it. Okay, how do we know it's working?
Pooping.
You're pooping a lot. Okay, we are going to monitor this patient for asterixis. What is asterixis? No, that's hepatic encephalopathy. But you're it's a test to test for that basically. So asterixis is something like, okay, let's say I'm taking care of a kidney patient and they all of a sudden start getting confused. And I'm like, oh no, what could be happening? I literally just told you. Why would they start getting confused?
Oh,
Yeah, there's ammonia in the brain, right? That's encephalopathy. So I'd be like, oh, I need to see if they have an ammonia problem. Now I will draw an ammonia level, but that's going to take a while to come back. At the bedside, I can go to the patient. If you push back their hands and you let go, if they have high ammonia, their hands are going to shake like this. That's bizarre, right? So we test for asterixis. So I can be like, oh, I already know it's high ammonia. I'm going to go ahead and start them on lactulose and neomycin and get rid of that ammonia. Do we understand?
yes.
Okay. What do you do for this problem? Antihistamines and lotion. And what do you want to do to their nails? Keep them clean and keep their hands. Because if they start scratching, right, and there's waste and stuff underneath, oh yeah, they'll get horrible skin infections. Do we understand?
Yes.
All right. Do we understand that function of the kidneys?
Yes.
Okay. Give me another one. Another function of the kidneys.
BP.
All right. So regulates blood pressure. How does it do that?
RAS
Through the RAS system. Very good. So it's constantly sensing, the baroreceptors are sensing low blood pressure, and it'll kick in the RAS system if it needs to. So what happens if the kidneys are broken? Can it regulate blood pressure anymore? So where does the fluid go?
Would it be third space?
No, it just stays in, it goes inside. There may be some third spacing. I do agree with that, but you're not peeing much. What's it called when you're not peeing much? Oliguria, right? Okay. So all that fluid is inside. So what's your blood pressure going to be like? It's going to be very high because they have lots of fluid left inside. Yes. Okay. If you've got lots of fluid inside, what's your biggest risk of hypertension? Stroke. Okay. And they're going to be in fluid volume overload. What's that going to do to their heart? Yeah, it'll make it go fast. It'll also put a lot of pressure on the heart too, right? So they could end up with, yeah, heart failure. Do we understand? This is a big deal. Yeah, we got to get rid of their fluid. I don't know why I can't speak today. I don't know what has happened to me. I feel like I'm in a brain fog for some reason. Okay. So what do you want to do for this patient? Fix the problem. How do you get rid of the fluid? You can give some furosemide, but their kidneys don't work good. So if Lasix is going to pull a bunch of fluid to the kidneys and the kidneys can't get rid of it, it's bad. So you will give some. Yes, dialysis will get rid of all the excess fluid. Okay. So what's the best indicator of fluid balance in this patient? A daily weight. We will still do eyes and nose, but daily weight is better. Yeah. So we're going to try to get rid of it with diuretics. Do you want to give them fluids? No. What are you going to tell them? You want fluid restriction, right? Because I don't want any more fluid, right? If their heart's having a hard time, where is that fluid going to back up to? The lungs. So what do I need to be real serious about doing? Auscultating for crackles. That's very important. That needs to be reported, because if there's fluid sitting in the lungs, what's going to happen to it? It's going to get infected. They're going to get a pneumonia. Yeah, which is really important to kind of note, eh? Okay. So if we're worried about stroke, we need to put them on neuro checks and seizure precautions. Yeah, we're going to check their blood pressure really carefully. And then they do dialysis typically 3 days a week. Monday, Wednesday, Friday. Got it? All right. Next function of the kidneys.
Electrolyte balance.
All right. So which electrolytes does the kidney balance? Sodium, potassium, chloride. All right. So that's the main ones. Now it will help out if the other ones get in trouble, right? Like which electrolytes will it help out with? If they get in trouble.
Calcium.
It'll help with calcium. It'll also help with MAC. Okay. Do we understand? So, okay,
Yes.
cool. All right. So if it is not able to balance electrolytes, your kidneys are broken, then what electrolyte imbalances will we go into? Hypernatremia, hyperkalemia, and hyperchloremia. Oh, I forgot to put chloride up there. Huh?
I was going to say hyperchloride.
Chloritis? What? All right. What's the first thing you're going to do for hyperkalemia? EKG. Yes. And then we need to bring down that potassium. Give me the 6 antidotes for hyperkalemia. I told you it's coming for you in every module.
Sodium.
K-Exolate, which is called
Sodium.
Oh,
Yes.
polystyrene.
I know what it looks like.
Okay.
I can't say it.
Sodium, polystyrene. Sulfonate. Okay. Y'all need to write this down 10 times. 10 times you're going to write this down, because this sucker is coming for you. Okay. K-Exolate, which is the actual antidote, right?
Yes.
Is called
Sodium
That's where it gets me.
Polystyrene
Sulfonate.
sulfonate. Write it 10 times on a piece of paper somewhere, because I'm telling you, it's coming for you. You will have it on exams like mad. Huh? All your pens aren't working. If they're broken, can you chunk them?
Yeah.
Okay. All right. We in Catholic school today.
Have you seen the acronym I saw on TikTok?
What? Acronym for what?
Potassium intense.
Oh, no, I haven't seen it. Sure.
It's called DIC.
Oh. We'll just talk about it in a little bit. Okay. Okay. Oh, I see it now.
Mhm.
Okay. Well, there's 2 more. So.
Well, yeah. But
Okay. Oh, I see.
it was like if you need, like if you don't know it and you like it's on the test or something like that. She was like, these are helpful. She gave you the other ones. It was a TikTok.
Oh, okay. You know how TikTok is.
Yeah.
Oh,
Yeah, I'll send it to you.
we'll do it. It's fine. And we can add the other ones too. Because I think I have an idea. How we doing?
Hands are.
Oh, now you want to learn your lesson today.
That's like ISS. They can have that.
ISS. You learn ISS?
Yeah.
In school suspension?
Yeah.
Oh, I was really bad.
You were?
Yeah.
I can't see that.
My dad beat my ass. So I was like trying to get attention.
Oh.
I asked my teacher if shit was a cuss word just so she could send me. No, but she was really, so it was like the last day of school and she was like, I don't want to see anybody putting anything in their toe tray. I was standing right next to it and I slipped my leg nail and she dumped my whole toe tray in my arms and was like, you're carrying it the rest of the day. And I was like, you got fucked up. So she was like, go to ISS. Like I was friends with the freaking principal. That's how much I was there.
All right, you ready?
Mhm.
Okay, so I added this because
Okay.
add dick. Okay.
Okay.
So what is, give me some of them. These are the antidotes to hyperkalemia.
Albuterol.
Albuterol,
Dialysis.
dialysis.
Extras.
I'm guessing that's what they're doing here.
That's what she did.
D50 plus
Yeah.
insulin.
Yeah.
If they're non-diabetic, right?
Yes.
Okay. And then C,
Calcium gluconate.
calcium gluconate. Oh, we about to get real weird in here because you're gonna need to add dicks. You perverts. All right, what's the K? K-exolate. Sodium.
Polystyrene.
No, that's K-exolate. There's another one.
Oh, sodium bicarb.
Yeah.
Yeah.
Yeah,
We
had to
were
take
just we were just practicing saying it.
Excuse me?
We were practicing saying.
Oh, okay. Good job, everyone.
Yeah.
All right. So those are the antidotes. We're going to do that. Okay. What's your keyword for potassium?
Heart.
Heart. So we're going to check EKG. What's your keyword for sodium?
Brain.
Brain. So you're going to do
Neuro.
neurocheck, seizure precautions, and hyperchloremia. We kind of don't worry so much about. Okay.
Got it.
Okay. So you want them on a low sodium, low potassium diet.
Yes.
Yes. Cool. All right. Give me another function of the kidneys.
Acid base.
Yeah.
Acid base balance. All right. So the pH of your urine is low. It's very acidic, right? Because your kidneys are constantly sensing how much acid you have in your body, and you're like, oh, you're so acidic, and then it will spill that acid into the urine. Does that make sense?
Yes.
Okay. So if that breaks, what happens?
Then you wouldn't have a lot of acid in your pee.
So where would it be?
In your
blood. So you're going to get very acidic. You're going to go into what acid-base imbalance? Metabolic acidosis. Very good. That was very simple. Yeah.
Yes.
Okay. When your kidneys break, who kicks in to help? That is not true. When you're talking about acid-base balance, there's only two systems. There's your kidneys and there's your lungs. Okay. So in your lungs, what is the acid? CO2. What's the base?
Oxygen.
O2. In your kidneys, what is the base? Y'all know it. Because you done just wrote it on the board. I literally just wrote it on the board. Sodium bicarb. Sodium bicarb is your base. What's your acid? Hydrogen. Okay, so those are your two acid-base systems, and they're there to help each other. So if one breaks, the other one kicks in. Yes?
Yes.
Okay, so right now, what's broken? Your kidneys. So who's going to kick in? Your lungs. So how are they going to get rid of the acid? Yes, Kussmaul's breathing. That's deep, rapid breathing. They're trying to blow out the CO2. Do we understand? So you may see Kussmaul's breathing. I'm telling you, I'm not okay today. I don't know what's wrong. I'm like super cloudy at it. And I'm just like, okay. So what's the nursing care for fixing this acid problem? No, because that's just the fixing system, right? We need to actually fix the system that's broken. So what can we give them? You can actually administer sodium bicarb, which is a base. Won't that help a little bit? Okay. And then I need to draw ABGs, right? Arterial blood gases that I know what their pH is. Yeah? Okay, give me another function. So far you said filters waste, regulates blood pressure, balances electrolytes, and acid-base balance. We have two left. All right, produces erythropoietin. What does erythro mean? Red blood cell. Poietin. To make. So erythropoietin makes red blood cells. What starts the system to make red blood cells? Hypoxia. Okay. So in the kidneys, they make erythropoietin whenever you need it, right? When your body's like, oh my God, you need some more red blood cells, you know? So, but if this function is broken, are you making erythropoietin?
No.
Okay, so let's follow through erythropoietin. Erythropoietin's job is to tell the bone marrow to make more red blood cells. So if you're not doing that anymore, then
Hypoxic.
they may be hypoxic because they're going to be
anemic.
anemic. They're going to be severely anemic. All of our kidney patients are very anemic. Now, yes, they do have a risk for hypoxia. Do not get me wrong with that. But they're not all walking around like that, right? They're just anemic. Okay, how do I know somebody's anemic? Yes, but how do I know for sure? How do I know for sure? 100% for sure they are anemic. What blood test would you like to do? Hemoglobin and hematocrit, right? That's how, y'all, we did like a whole 4-hour session on effing anemia. Okay. All right. So we're going to draw hemoglobin and hematocrit. What else do you want to do for our patient for anemia? They do not need iron. They are not deficient in iron. Remember, we talked about with anemia, there's lots of different anemias. You have to match it up to, I know you really like iron though. You just love the shit out of iron. Oh, okay. Go on. How do they feel? What's a treatment? What's a nursing care for anemia? Okay, well, the kidney is the problem and I can't fix it. So how do you think they will feel? Really tired, right? Because they don't have enough oxygen, right? Frequent rest periods. And if their risk is hypoxia, I probably want to monitor that with a pulse ox. And if their hemoglobin goes less than 7, if they go very low, yes, you can give them O2. We may need to give blood transfusions.
Oh yeah, that lady. I was gonna answer her hemoglobin was 8.3.
Oh, nice.
So they were.
Did they transfuse her?
They said that they had it on standby.
Yeah. So most of the time they won't do it until at least less than 8. Yeah. Some hospitals go less than 7 before they'll transfuse. Okay. Do we understand that function? All right. We got another one. One more. It's a vitamin.
Vitamin D.
Yeah. All right. So it synthesizes vitamin D. Okay. What's vitamin D's job?
It's just a marry with calcium.
It marries with calcium to help absorb calcium. It also has major immune function, right? Because vitamin D is really more of a hormone than it is a vitamin. Yeah.
Oh yeah.
Okay. So if they're not producing vitamin D because the kidneys are broken, then what happens?
They'll have they at risk for osteoporosis.
Why?
Hypocalcemia.
They have hypocalcemia, which means they're also going to have hyperphosphatemia. Yes.
Yes.
So yes, they're at risk of osteoporosis. They may have frequent fractures. Yeah.
Mhm.
Yeah. What's the disease called where you have deficient vitamin D?
Rickets.
Rickets. Rickets. Yes. Okay. All righty then. So what am I going to do for this patient?
Give them vitamin D.
Yeah. And
Would you give them calcium?
you would
Yeah.
give him calcium too. Vitamin D and calcium.
Okay.
What kind of exercises?
Weight bearing.
Weight bearing exercises. I need to get rid of that phosphorus. So we're going to give them phosphate binders. Those are medication you can give that grabs phosphorus and helps you get rid of it. It is called Phoslo.
Yeah.
Yeah.
That's
All right.
Nice.
That is nice. Thank you, Lord. All right. We want them on what type of diet
Low.
in this function? So yes, hold on to that. So we want them on a high calcium, low phosphorus, but they cannot have dairy because it has both, right? So there's no dairy for any of our kidney patients, right?
Yes.
Right. Okay. Do we understand all the functions of the kidneys?
Yes.
Now, what we're going to do when we start going into AKI is all of these right here, signs and symptoms of your AKI and CKD. This is it, all in one page. All the signs and symptoms and all the nursing care of AKI and all the nursing care of CKD all on one page. Do you understand how to do this?
Yes.
Okay. So that's your whole plan of care. That's one whole PowerPoint in one page. Enjoy. All right. Ready?
Yes.
All right. So we're gonna do causes of renal failure.
Got it.
Okay. So heart pumps out the
Aorta.
down the abdominal aorta and directly to the
Renal.
renal arteries, which provide blood flow to the kidney. What happened? Did you pop your
That was
back or
good.
something? Oh, no, you're just happy y'all got it. Oh, okay. I thought like something happened, like your bra popped or something. Cause you were like, oh, all right. Okay. So we're going to talk about what can cause kidney failure. There's pre-renal, which means anything before, intrarenal is anything inside, and then post-renal after. Okay. So pre-renal, what could cause kidney failure before the kidneys? Oh, what the?
Shock.
Yes, shock. Right? If the kidneys do not get blood flow, do they not die?
Oh yeah.
Yes.
Oh, yes, yes. So you can say it in a million different ways, but anything before the kidney or pre-renal is going to be a blood flow issue. You can say hypovolemia, which means
Low
Low-
pressure. Low volume.
low volume, right? They don't have enough volume to perfuse the kidneys. You could say dehydration. That's still low volume. You could say hypovolemic shock. Low blood volume. Do you understand what I'm saying?
Yes.
Okay, so it doesn't matter how you say it. It's your kidneys did not get enough blood flow and then they have died. Now, can they rise from the dead?
Yes.
Yes, that's why the body pulls blood flow away from them in shock, right? So, but it depends on how long they went without blood flow. If we coded somebody for 90 minutes, their kidneys are probably not coming back, right? They may have kidney failure for the rest of their life, even though we brought them back to life. Okay. So it depends on how long it went without blood flow to how well their kidneys are going to do afterwards. Do you understand what I'm saying?
Yes.
Okay. The only other thing that could possibly happen pre-renal, which I didn't even write it down because I don't know if they would have touched it, is that there's a clot in the renal artery. Doesn't happen very often, but if there's a clot, that's still a blood flow issue. Y'all can draw a clot in there if you want to. Okay. Intrarenal means anything inside. Okay. So this is damage to the glomeruli. This would be damage to the nephrons, damage to the actual kidney. Okay. When I was in nursing school, I thought AKI meant like literally somebody punched you in the kidney. Do you know how often that happens? How do you punch somebody in the back? You know, like that is not what AKI means, acute kidney injury. Now, could it happen that way if you get beat to shit?
Yeah.
Maybe, but you know how hard it is to kick somebody in the kidney. It's up here. You'd have to be like a, yeah, like a kung fu fighter or something. So that's not really what AKI means. An acute kidney injury means your kidneys are like injured because they didn't get blood flow or because something bad happened inside the kidneys, usually a disease process. Now we're going to go over these really quickly because we'll talk about them later more in detail, but do y'all know what APSGN is?
It's like post-strep.
It's a post-strep glomerulonephritis. So we will talk about this in great detail, but basically what happens is you get a strep infection, your body responds by producing an antibody, right? To like kill the strep. The antigen antibody complexes are very large, and the only way to get rid of them is through the kidneys. So these complexes go to the kidneys. The glomeruli is only this big. The complexes are this big. So they rip their way through your glomeruli. The glomeruli bleeds, obviously, because you ripped it, and then it swells shut. Because you can't get rid of any fluid or anything. Okay. So that would be something that's happening inside the kidney because the glomeruli are inside the kidney. Yes. What is nephrotic syndrome?
Protein.
Yeah, so, but we don't know exactly what causes it. What we do know is there's some kind of damage to the glomeruli. So like in APSGN, the doors are slammed shut and they're swollen. In nephrotic syndrome, for whatever reason, the glass doors break and they are wide open. So they allow protein, okay, they allow proteins to come out and other things to come out that wouldn't normally come out before. That's damage to the glomeruli. That is a intrarenal problem. Yeah, we'll talk more later too. Okay, that was more than your doctor taught you. What is pyelonephritis?
Inflammation.
Infection of the kidney. It's an infection of the kidney.
Is that where the blood comes out? And
You can have some blood, but mostly it's just pus.
okay.
No,
Yeah.
no big deal. Just, pus in your urine seems normal. All right. So pyelonephritis is infection of the kidney. Okay. Nephrotoxic drugs. And I mentioned those at the beginning on that first sheet, right? So big ones are like vancomycin, gentamicin, like big ones like that. Okay. Malignant hypertension. Now, malignant doesn't mean cancerous in this case. Okay. It just means like this is very bad. All right. Hypertension. So we said hypotension will cause what type of renal failure? What type of renal failure? Pre-renal. But hypertension will cause intrarenal because you've got the sliding glass doors again, right? What happens if you are pointing a giant fire hose and spraying it at these glass doors?
You're gonna break.
It's going to bust them open. So hypertension over time will bust up all your glomeruli. Does that make sense?
Yes.
Okay. All right. Lupus. What are two keywords for lupus? Skin and kidneys.
Sorry.
Sister. All right. Lupus is what type of disorder?
Autoimmune.
Autoimmune, and it likes to attack the
Kidney.
and the.
Skin.
Oh, you're afraid to say it now?
Yeah.
Okay. All right. Acute tubular necrosis. So acute means
Short-term.
right now.
Yeah.
Acute means it's happening right now. Tubular. Renal
Renal.
tubules. Necrosis.
Yeah.
Dead. It would be bad if your renal tubules were gone. Yes?
Yes.
Okay. So that's all stuff that's happening inside the kidneys. Do we understand?
Yes.
All right. Now let's look at post-renal, things that are happening outside or after the kidneys. Okay. It's got to be some kind of obstruction, right? Right?
Yes.
Okay. So you could see a renal calculi. What's renal calculi? A kidney stone. You see, I drew one right here. If it's blocking, like it's in the ureters and it's blocking, then can the urine get out?
No.
No. So it's stuck in here and it's going to make the kidney big and full of urine. What's that called when your kidney is big, giant, full of water? No, urinary retention's here in the bladder.
Yeah.
Okay. When your kidneys get very large, full of fluid, full of water. What's the term for water? Hydro. What's the term for kidney? Neph. So hydronephrosis. Yes, 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 Lord. All right. So a kidney stone that could be blocking that side, right, can cause urine to back up and cause kidney damage. Yeah.
Yes.
What is BPH?
Benign prostatic hypertrophy.
Very good. Benign prostatic hypertrophy. Is it cancer?
No.
No, because it's benign. Where is the prostate?
Wrapped around.
It's wrapped around the bladder neck. See, I drew it right here. The prostate is wrapped around the bladder neck. So if there's something wrong with the prostate and it is swollen or it is like big, it's going to like squeeze on the bladder neck and squeeze on the urethra. Yeah. So if urine can't get through, it's going to back up into the ureters. It's going to back up into the kidney and cause hydronephrosis, which will eventually cause kidney failure. Yeah.
Yeah.
Okay. Any kind of tumors down there. And this could be like female tumors, right? This could be an ovarian, something, because it's all right there in the pelvis, right? So any kind of tumor that's down there, could be colon, any of those things. What is VUR? Have y'all heard of it before? Do you know what this is? Okay, then I will write it on the board because it's a new concept. Okay, so it is vesico-ureteral reflux. Vesico-ureteral reflux. You know what GERD is?
Yeah.
It's the GERD of the ureters. Okay, so the urine goes down, it's like, whoop, nope, goes back up, goes back down, whoop, goes back up, just like GERD does in your stomach. Yeah.
Yes.
Okay. So this is usually caused by a structural defect. Okay. So, and this is something you're born with. All right. So if this is your kidneys here. Okay. What's coming off the kidneys right here? And what is this tube right here that comes off the kidneys? The ureters. Okay. And then that goes into your bladder. Okay. And then your bladder goes into your urethra, and then you pee stuff out. But what the BUR is they have some kind of structural defect of the ureters. Okay. So maybe their ureters go like this. They're very narrowed, right? So when they try to pee, like it goes down, but it's like, ooh, it's kind of near, like I can't quite, I'm gonna go back up. I'm gonna go down. Do y'all see how it's the GERD of the ureters?
Yes.
So they can't quite get rid of the urine. So where does it back up? It backs up into the kidney. Okay. There's 4 different stages of BUR. Maybe that's what you, no, okay.
Oh.
So there's stage 1 through stage 4, and they go in order of severity. Stage 1 or stage 2, like I don't really do a whole lot about. Sometimes when the kid gets bigger, they'll just grow out of it because their ureters get bigger. And they kind of stretch out a little bit, but grades 3 and 4 have to be surgically corrected because a grade 3 or 4 might look something like this. Right? Urine's not going to go through there very well. Right?
Yeah.
And so it'll go down and come back up and go down. And that urine just sits in there for a long period of time before it actually gets down to the bladder. So what do you think? Patients with BUR, what do we see? Okay. If this urine's been sitting in here for a very long time before it gets down to the bladder, what do you think you're going to see?
Infections.
Yeah, they get frequent UTIs, and usually as a baby, and that's how we're like, UTIs in a baby is not normal. So that's how we would know, like, this isn't right, right? So in BUR, if it's 3 or 4, they have to go and do surgery on it. If it's 1 or 2, they may just give like low dose prophylactic antibiotics. So that way the kid doesn't keep getting UTI after UTI after UTI until hopefully they grow out of it. Does this make sense what BUR is?
Yes.
Okay. So that could be a cause of, or post-renal cause of kidney failure. Okay. Do we understand?
Yes.
What is prostatitis?
Inflammation of the prostate.
Yeah. And where's the prostate? What is the prostate's job?
It is the fluid that the semen is in, right?
It's the fluid that the sperm is in, right? So it,
Sperm.
yes. Okay. You're turning red. So sperm is just the swimmers, and those come from the testicles,
Yeah.
right? But there has to be fluid, like a medium at which they can swim in. Your face is so funny. And so the prostate makes the seminal fluid. So both of those have to work together for a dude to ejaculate. Yes? Because if you can't just spit out swimmers, that'd be so creepy. It's like they're coming for you. Yeah, it has to be able to swim in some kind of fluid. So that's what the prostate does. Okay. But when you have prostatitis and it's big and it's swollen, it's going to wrap around the bladder neck and it's going to like squeeze it. And then they can't get any urine out. It's going to back up. Do we understand?
Yes.
Do you understand pre-renal, intrarenal, postrenal?
Yes.
Good. Good job. Good job, everyone.
You're
Yeah. All right. Stages of kidney failure. There's actually one more that I'm going to add. It doesn't need its own column or anything, but all right. So, oh, I need to tell you all something else too before we start this. So when there's been a kidney injury, okay, so that's an AKI. And we understand all the different causes of AKI because we just did them: pre-renal, intrarenal, postrenal. Okay. What will immediately happen is they're going to go into, there's a different phase that comes right before this. It is called the onset phase. Okay. So immediately your kidneys are like, what what just happened? Right. It's like a concussion of the kidneys and they're like freaking out. So they're like, I don't know what happened, but I'm just going to hold in all this water because I don't know if I'm supposed to let it out or not because I'm confused. Okay. So the only thing you're going to see in onset is an immediate, what we call a delusional hyponatremia. Okay. Tell me what that means. What does to dilute mean? To water down. What is hyponatremia? Low salt. So when your kidneys are like, oh my God, something bad happened, but I don't know what it is, and they just hold in all their fluid, it's going to water down your salt for a short period of time. So you may see hyponatremia before you see hypernatremia. Do we understand that?
Yes.
Okay, then after that, we're gonna go into the oliguric phase, which I'll talk about more in just a second. Now, one of two things is gonna happen from the oliguric phase. Either your kidneys are gonna get better or they're not. Okay, those are your only two options, okay? If they weren't like without blood flow for a super long time, like let's say we coded the patient for like 15 minutes, you know, and then the kidneys came back, they didn't totally die, the kidneys are gonna recover, then we go into the diuretic phase, okay? And then we will go into the recovery phase. And everybody's happy because you like healed their kidneys. They'll never be exactly like they were before, okay? But it's better, you know, you've got better. If the kidneys without blood flow for a very long period of time and they done died, okay, it's not coming back, right? So you're gonna end up in renal failure forever, okay? Now we can do dialysis, doesn't mean you're dead, right? We can do dialysis and things like that to help you. You may also hear it called ESRD. What does that stand for? End-stage renal disease. They may also end up with CKD, which is chronic kidney disease, or they may call it ARF, which is acute renal failure. No matter what happens, it basically is saying like the kidneys did not come back. Okay, and we're gonna need to support them lifelong because they're not coming back. Do we understand?
Yes.
Okay, so we're gonna follow this first and then we'll go into that. So something bad happened to their kidneys. Yes. Let's say they coded, it was 45 minutes and their kidneys are like, "Ooh." So immediately they're gonna hold in water. That's gonna cause an immediate dilutional hyponatremia, okay? Then the kidneys are gonna be like, nope. And they're not gonna work anymore. The kidneys are stopping functioning because their job is to stop right now and heal. So they can't do any of the 6 functions we discussed before. Do you understand that?
Yes.
Okay, so you're gonna go into the oliguric phase. Okay, so oliguria means less than 424 hours. Now we don't do hourly anymore, okay? What is a normal hourly urine output for a patient? 4D? We're all D? No, it's 30 an hour. 30 mLs an hour is a normal urine output. However, because these patients are in kidney failure, we don't do it per hour, we do it per 24 hours, right? Because just because you don't pee in 4 hours, like you just didn't pee it, right? Doesn't mean you have no urine. Yes? Okay. So less than 424 hours. Y'all, that's not very much at all. It's like half a water bottle. Okay. So that's bad. Now, anuria is like less than 50. Is that what I said?
Yeah.
Yeah. That is nothing. So you're hardly ever going to pick anuria on an exam because there's hardly anybody that is producing that little urine. Okay. So if you notice, a lot of these signs and symptoms are going to sound familiar in the oliguric phase. Okay. Hyperkalemia, hypernatremia, hyperchloremia, hypocalcemia, hyperphosphatemia. Have we not talked about these already? Hypertension, fluid volume overload, decreased GFR, metabolic acidosis. Yeah, see, so that's where this paper at the beginning comes into handy, right? Comes into handy. See, I can't do it today. Comes in handy. Okay. All of these are signs and symptoms we already discussed because the functions of the kidneys are broken. Does that make sense? Their urine specific gravity is going to go up because the urine is going to be very concentrated because your body's holding on to that fluid. They'll be in fluid volume overload, decreased urine output. They may have a little edema, weight gain, fatigue, malaise, azotemia. Haven't we discussed all of these already?
Yes.
So you already knew it was coming.
Can you say what azotemia is?
Yes. What was azotemia? Buildup of all the waste products in the blood. Okay. All right. So how do we treat it? We're going to do what we've already talked about before. See if this sounds familiar. Decrease their potassium with the 6 antidotes, antihypertensives, calcium supplement, phosphate binders, vitamin D, calcium supplements. Haven't we already talked about all of this? You already know it. Okay. Okay. Diet, low potassium, low sodium, low phosphorus, and low uric acid. What are sources of uric acid? Yeah. So they can't have red meat either. And no dairy. Oh, this was your diet.
Yay.
She's on the renal diet. High calcium and high vitamin D. Do we understand all that?
Yes.
Okay. This phase usually lasts 8 to 14 days, but it could last longer while your kidneys are healing, recovering, doing their thing. Now, here's the thing. This is about to make a rapid shift, right? It's going to flip on its head in an hour. See, this person may be in the hospital. You've had them in ICU. We've been doing this for 3 days in a row. Same thing, same thing, same thing, same thing. Then all of a sudden, you look down at their urine bag and they've peed out 3 liters on the floor. It's like overflowing the urine bag. All of a sudden, they switched into the diuretic phase. So oliguric means I held it all in. Diuretic means
Let it
I
out.
let it all out. So we're going to go back to that page we did before. This one with all the functions of the kidneys. Okay. Now, all of these were all the signs and symptoms of the oliguric phase, right? When we go into the diuretic phase, you're basically going to flip it upside down, right? So before, when we had hyperkalemia, now they're going to have hypokalemia. They had hypernatremia. Now they're going to have hyponatremia. They had hypertension. Now they're going to have everything is flipped upside down. Does that make sense? That's why I said everything is on this paper. Okay. You understand what I'm saying?
Yes.
You have to be prepared to completely flip their plan of care upside down in an hour, right? Because before we had fluid restriction, now we need to give them tons of fluids because they're getting very hypotensive. What's the risk? Another AKI, right? Or shock. Yeah. So we could harm them again if we don't get on this. Before we were restricting potassium. Now their potassium level is 3.2. Now I need to give them potassium. So do you see how it flips?
Yeah.
Okay. So you'll see all the signs and symptoms are flipped upside down. Yeah.
Mhm.
Okay. So the BUN and creatinine are going to start. What's wrong?
I heard something like this.
Like someone coming in the door? Or...
I don't know.
Huh? Would y'all like me to go check it out? No, I'll do it. Okay. So for the diuretic phase, we understand everything is flipped on its head. Yes.
Yes.
Okay. So the BUN and creatinine, that does not mean it's low. It means it's starting to come down. The GFR may start to go up, but probably not yet. Okay. It may start to, but GFR is like how well your kidneys are filtering, like they're filtering well. Okay. So they're going to have massive weight loss. Okay. This begins when diuresis starts. Then we're like, oh, dang, they in the diuretic phase. Then we have to fully change the plan of care. Do you understand?
Yes.
Okay. They may last in that for 7 to 14 days, sometimes longer. Yeah, this is not a joke. And then once that GFR really starts to increase on a daily basis, that's when we're like, okay, we're in recovery. Because before an oliguric, most things were super high and then they went super,
Low.
and now I want them in the middle. So that's what recovery phase is. Now, this is going to take months up to years for them to fully recover. But remember, they're not going to ever fully recover,
Yes.
right?
Mhm.
Okay. Sorry, what?
Can we say it's stabilizing the recovery phase?
Yeah, recovery phase is when like the kidney has actually healed itself and everything, like your lab values are normal. Like they're going home for this. They're not going to be in the hospital for a year. And we're just periodically checking BUN, creatinine, and GFR. Our goal is to get them to 80% of the GFR they were before the injury happened. Because like once you inject up your kidneys, like they're never going to be exactly normal, right? Okay. Do we understand stages of kidney failure?
Yes.
Beautiful.